Hello and welcome to lecture number 8 in our continuing series on drugs and human behavior. Today we're going to talk about psychedelic drugs. These are drugs primarily that are known to cause a variety of psychedelic effects, such as alterations in perception, alterations in sensation. These are drugs that include psychedelic mushrooms, which is psilocybin, PCP, ketamine, MDMA or ecstasy, and drugs like scopolamine. So we'll start with different categories of psychedelic drugs. We'll talk then about scopolamine, followed by mescaline, followed by MDMA or ecstasy. Talk briefly about other synthetic amphetamines, talk about hallucinogenic drugs such as LSD and psilocybin, and then finish up with some other drugs in this category like ketamine, PCP, and dextromethorphan. In terms of the categories of psychedelic drugs, we refer to these primarily by their mechanisms of action. So the anticholinergic drugs, of which scopolamine is the sort of exemplar in this category. The cataminergic drugs, which include mescaline and MDMA. The serotonergic drugs, which are LSD and psilocybin. And then glutamatergic and NMDA receptor antagonists, which include 2 psychedelic anesthetics and dextromethorphan. We'll start with the sort of king of the anticholinergics, scopolamine. This is the prototypical anticholinergic psychedelic. It is a competitive antagonist of the muscarinic type of the acetylcholine receptor. It causes delirium and intoxication. It's an amnestic, causes drowsiness, mild euphoria, fatigue, mental confusion, loss of attention, dreamless sleep, and clouds rather than expands consciousness. Medically, it is found in some travel sickness products or patches, so scopolamine patches oftentimes will be prescribed for people who get severe levels of seasickness. Significant problem with that is scopolamine does cause some level of amnesia, and so it's something to keep in mind. Some common anticholinergics include scopolamine, atropine, and L-hyoscyamin. Atropine is often used as an antidote for other procholinergic drugs, such as pesticides. The historical background of scopolamine is it's widely found in nature. It has been used and misused for centuries. Some common elements of the history of scopolamine is it was associated with sorcery, magic, witchcraft, and aphrodisiac. Reports often include the sensation of flying, which is why this is associated oftentimes with witchcraft and magic. Scopolamine is found in potato, tomato, eggplant, and pepper with no hallucinogenic properties. The mandrake root, however, does have some hallucinogenic properties. And then finally, deadly nightshade, which is Atropa belladonna, which is a form of atropine. Henbane, datura, which is also known as Jimson weed, which was implicated in some issues at Jamestown. The effects of scopolamine include increased heart rate, dry mouth, constipation, blurred vision, drowsiness, and amnesia. When we get to levels of toxicity, it includes delirium, mental confusion, increased temperature, nausea, vomiting, fixed and dilated pupils, and hallucinations. Atropine, if you remember, is often used, or belladonna drops were often used to cause pupil dilation. In fact, atropine drops can be used to dilate your pupils. And so were used for some time as ways to increase attractiveness because our pupils dilate when we find someone attractive. And so the effects of scopolamine include fixed and dilated pupils. As you can see, while scopolamine does treat seasickness, the side effects are pretty severe. Particularly amnesia is something that scopolamine is known to affect. Most deaths due to accidental overdose or intentional poisoning or suicide. So people are sometimes poisoned with drugs like scopolamine or other anticholinergics. Mescaline is the next psychedelic drug I want to talk about, again, fairly briefly. This is taken from the plant the peyote cactus plant. It's found in the peyote cactus in Mexico and the southwestern United States. It's legalized as part of a sacrament of the Native American Church. In fact, the way peyote is used is in vision quests, so the psychedelic drug is used as a way to try to find spiritual enlightenment through the Native American Church. The pharmacological effects of mescaline, these buttons that you see on the outside of the cactus are chewed, and you get an onset in about 30 to 90 minutes of the effects. The duration is about 10 hours, and the drug is excreted entirely unchanged. The effects of this drug include a variety of visual hallucinations, basic psychedelic phenomenon. This is one of the reasons why it was used as a way to gain spiritual enlightenment through these vision quests. If you look at the structural formulation of different drugs in this class, you can see that mescaline is highly similar to norepinephrine, amphetamine, and some other drugs in this class we're going to talk about. We'll talk about MDA, which is a derivative of, which is related to MDMA. But you can see these are all fairly closely related in their chemical structure. So these 8 drugs are structurally related to norepinephrine and are thought to exert their psychedelic actions by altering the transmission of nerve impulses in norepinephrine and serotonin synapses in the brain. Ecstasy, or MDMA, which is methylene-dioxymethamphetamine, is metabolized to methyldioxyamphetamine, or MDA, but it is less than hallucinogenic with less extreme visual distortions and disembodiment. It can be associated with severe toxicities including death, hyperthermia, which is overheating, tachycardia, renal failure, disorientation, convulsions, and muscle breakdown. The central nervous side effects of this particular psychedelic drug include depersonalization, paranoia, anxiety, panic, suicidal ideation, disruption of homeostasis, including hyperthermia, and reduced thirst satiety. These are probably the most important side effects to be mindful of. Very few people ever overdose on ecstasy. Usually what happens is they get such disruption in their homeostasis system that they overheat, so they become hyperthermic because they lose the ability to regulate their body's internal temperature. And oftentimes they're, of course, at raves where they're dancing and there's lots of other people who are hyperthermic, and so it's really hot, and so they just overheat. The other problem is from reduced thirst satiety. So ecstasy has an effect on parts of the brain that are responsible for telling us whether we're thirsty, hungry, etc. And one thing that can happen with ecstasy users is they can get this reduced thirst satiety. So they constantly think they're thirsty. As a result, they keep drinking water, and keep drinking water, and get what's called water intoxication. Because they flush all of the electrolytes out of their system, they end up having a heart attack as a result of that loss of electrolytes. So it's something to certainly be mindful of. Despite this intense euphoric high associated with MDMA promotes its continued use. This is obviously a drug that's used primarily in sort of nightclub scenes. Some people use it, as a sort of marital aid, as it were. We'll talk a little bit more about some of the history of the use of MDMA and its pharmacokinetics as we continue talking about it. MDMA is metabolized to MDA, which is an active metabolite. The time to peak plasma concentration of MDMA is around 2 hours. It takes about 2 hours for a roll to kick in. But about 6.5 hours after ingestion, you get peak of the active metabolite MDA, so this is the second peak of drug plasma concentrations. The elimination half-life is approximately 9 hours for MDMA and 25 hours for its active metabolite MDA. So it's a pretty long half-life. So we're talking about a very, very long time this drug is going to be in someone's system. So if you look at the pharmacokinetic parameters for MDMA and its metabolites, and this comes from therapeutic drug monitoring, You can see here the time to maximal plasma concentrations is about 2.3 hours, plus or minus 1 hour. The plasma elimination half-life is on average 9 hours, again plus or minus about 2 hours, from 7 to 11 hours in participants. But the elimination time, time to maximum plasma concentrations of the active metabolite MDA is closer to 7 hours. And again, the plasma elimination half-life is about 25 hours with a huge amount of variance. So anywhere from 10 to 40 hours for the participants in this particular study seem to be quite a bit of variance in these particular 8 subjects. So keep in mind that while MDMA will wear off relatively quickly, so 5.5 half-lives, we're talking about not quite 40 hours, it's going to be 5 days before the active metabolite has completely cleared the system. So that's a pretty long time. So again, if you look at the concentration time over the course for a dose of 100 milligrams over the time frame, you can see in the top left corner is the concentration of MDMA. So it peaks again about 2 hours and drops off pretty dramatically. And so probably about 12 hours is really lost its punch. And then the MDA concentrations, however, are certainly 12 and 24 hours later still relatively high for a person taking this particular drug. So one of the issues to keep in mind with the pharmacokinetics of ecstasy is it causes metabolic inhibition for approximately 24 hours. And so additional doses will have a much larger peak plasma concentration amounts. And that can result in toxicity. So because the drug isn't being metabolized out because of a previous dose, that second dose is going to last much longer and pack a much larger punch. And so it's something to be mindful of if this is something you or your friends might be doing. Just simply be mindful of the fact that taking that second dose is going to pack a much bigger punch than the first one. So ecstasy has effects on both 5-HT, which is serotonin, and norepinephrine. It's a potent and selective serotonin neurotoxin in animals and humans, and has been shown to damage the serotonin transporter. Symptoms of the sort of chronic effects of, or acute effects of ecstasy include teeth grinding, muscle tension, nausea, depression, anxiety, panic, mental confusion. Over time, there's more tolerance to the positive than negative effects, so the positive effects decrease while the negative effects do not. And so that's, again, something to be mindful of. Open question about whether or not ecstasy causes cognitive deficits in humans. There is some evidence in animal models, but the animal models, they tend to give very large doses of ecstasy, and so it's oftentimes difficult to know whether or not those animal models translate well to humans. So their toxic reactions often occur during periods of intense activity, such as raves. This hyperthermia, tachycardia, disorientation, dehydration, dilated pupils, convulsions, rigidity, and kidney failure. Kidney failure and dehydration obviously go hand in hand because there's loss of fluids, kidneys can shut down. And again, that hyperthermia can be particularly dangerous, and that's probably what's causing that tachycardia. The combined use of ecstasy with LSD, which we'll talk about here in a minute, is called candy flipping. And this produces synergistic effects in rodents. And so, something to watch out for. That's a lot of stuff going on. Potential neurotoxic effects. Striatal serotonin is depleted in the brains of heavy chronic ecstasy users. These are people who have taken 281 pills for the previous 6 years. The 5-HT and 5-HIAA serotonin transporters were severely depleted by about 50 to 80%, and dopamine levels were unaffected. This drug primarily affects serotonin levels. The behavioral effects of ecstasy, we believe, is caused by massive release and then subsequent depletion of brain serotonin. One thing we do know from some minor research in this area, looking at observational effects, is that several days after, 2, 3, 4 days after dosing with ecstasy, there is a massive depletion of brain serotonin, and people who have taken these drugs earlier in the week oftentimes show marked amounts of depression. And so it's something to be mindful of. Somebody who takes a pill on Saturday, by Tuesday they're going to feel pretty awful. The problem is that it's so far delayed from taking the drug that the two aren't really learned together. So something to watch out for. So that's ecstasy. There's evidence for its neurotoxicity. There's not great evidence that it causes long-term cognitive declines, but certainly something not to be done in heavy amounts. So if it's something you're going to do, be responsible, and certainly watch out for some of these side effects that we've talked about. So there are other synthetic amphetamine derivatives that are structurally related to mescaline and amphetamine that produce similar effects. These are DOM, MDA, DMA, MDE, TMA, and MDMA is structurally similar. These are behavioral stimulants with increasing LSD-like effects as doses increase. They're more toxic and more potent than mescaline. And it's this alteration of the mescaline molecule that produces the family of drugs similar to amphetamine. They're usually more potent and potentially more toxic. Again, this is one of those areas where chemistry oftentimes is ahead of what we know from a research perspective. And so anything that is new and untested sort of in the marketplace is probably something certainly to be avoided. Ecstasy used to be legal. It's one of the things that we talked about when we talked about the Controlled Substances Act. So it used to be available over the counter until the 1980s, and then it was placed in Schedule 1. There is some emerging evidence as for the potential therapeutic use of MDMA in post-traumatic stress disorder. That's something we'll talk more about when we talk about alternative treatments for things like depression. Types of synthetic amphetamines include things like DOM. It produces euphoria and about 6 to 8 hours of hallucinations. It's more potent than mescaline, not as potent as LSD, but in high doses it's quite toxic. MDMA or MDE or DMA, TMA, these are designer psychedelics. These actions are pretty similar to MDMA, but have very different metabolic properties. So again, something to be mindful of. If it's something different, it may have very different properties if it's something you think you've taken before. The hallucinogens are primarily serotonergic. In this class, the sort of granddaddy of them all is LSD, or lysergic acid diethylamide. Psilocybin and psilocin are similar, but the problem with these drugs is the actions on serotonin receptors is unclear. The structural formulas of serotonin and 6 serotonin psychedelic drugs are very similar, so there's likely a mixed bag of serotonin actions. The effects of these drugs are primarily visual distortions and psychic effects that predominate over any somatic effects. You get changes in mood, thought disruption, altered time perception, depersonalization, hallucinations, and potentially psychotic episodes. This kind of altered time perception, depersonalization, and hallucinations is one of the reasons why LSD was thought to be this sort of new spiritual awakening, where you could explore new possibilities through new realms. It's through those processes that this kind of came to be an almost religious-like phenomenon. So the structural formulas of serotonin and these serotonin-like drugs are very similar. You can see serotonin at the top, DMT, psilocin, psilocybin, LSD, all sort of very similar. A little bit of the history of LSD. 1943, Sandoz Pharmaceuticals was experimenting with ergot derivatives, ergot, which is a fungus found in rye bread, accidentally absorbed through some of his skin. He described and reported the sensory distortions of the drug. Scientists developed in the hallucinations because hallucinations also occur in schizophrenia. We haven't talked about schizophrenia yet, but these are not the same. Very few schizophrenia patients have visual hallucinations. Primarily, they're auditory hallucinations. So that was sort of a dead road. There is a history of some unethical and illegal use in the military and in the CIA. There is some reports of the CIA dosing a group of scientists and just sort of seeing what happened, and allegedly one person jumped out of a window. There's a long sort of history of the potential idea of using this drug to discredit world leaders. So I think this was back in the era of trying to discredit Fidel Castro, as an example, by dosing him with LSD. So Timothy Leary and Ken Casey are associated with the sort of turn on, tune in, and drop out movement. In this era, their thought was that you could use LSD as a way to get people to sort of dissociate and be part of their psychotherapy. That was unsuccessful. There were a lot of unreliable protocols and measures, but there was a dramatic increase in recreational use of psychedelic drugs. Again, we start arriving at the summer of love. Again, the CIA and other government agencies conducted some secret experiments on hallucinogens, and the history of that is fairly grim. So hopefully, of course, the government's not doing any such thing anymore. LSD was made illegal in the 1960s and placed in Schedule I categorically viewed substances, not suitable for therapeutic use. This is sort of part of the response to the thalidomide epidemic of birth defects. And so this era saw some pretty dramatic desire to regulate drugs more closely to make sure that they aren't causing damage. Pharmacokinetics of LSD, it's rapidly absorbed orally, usually within 60 minutes, and peaks around 3 hours. It's a very potent psychoactive drug. Only 1% of this drug gets into the brain. The usual dose is 25 to 30 micrograms. Very, very low. Because of that low dosing, it's really difficult to detect in urine, but it can be detected with very sophisticated techniques for up to 30 hours. It has a long half-life. It's distributed easily throughout the body, brain, and placenta. But again, very, very small amounts make it into the brain. And it's metabolized in the liver, much like all the other drugs we've talked about. It has low toxicity. The lethal dose of LSD is 14,000 micrograms. People usually die using LSD by getting violent or doing something that they think is appropriate, like flying when they can't. So they'll jump out windows and do sort of insane things like that. So that's where we get to the psychological effects. There's a perceptual phase that's associated with colored lights and distorted and very vivid images. You can get unpleasant panic experiences can occur due to these sort of overwhelming visual and emotional effects. Some adverse reactions include potential for flashbacks. This is now called hallucinogen persisting perception disorder. So it's a potential for a long-term effect. These are generally people that have done a lot of this particular drug. There's a rapid onset and loss of tolerance. There's a little bit of cross-tolerance across different hallucinogens in this class. But there are no physical withdrawal syndromes. So this is not an addictive drug at all. So because this is such a small microdose, it's the reason why a liquid is usually put on the back of little squares called stamps, and that's what people lick. And that's usually how they end up dosing their LSD, and that's kind of how their dosing is regulated, is 1, 2, 3 stamps, depending on the dosing. Other serotonin-like hallucinogens include DMT, which is a sword-acting LSD-like. It binds to serotonin 2 receptors. Has to be smoked or sniffed. It's inactive orally. Sometimes it's included in marijuana cigarettes. It's metabolized by monoamine oxidase, so it may be bound to sigma-1 receptors as a possible mode of action. Its onset is generally in 2 minutes. It's about a 30-minute effect. One of the 2 main ingredients in ayahuasca, also called huasca. Psilocybin and psilocin are the primary hallucinogens found in species of mushrooms. So when people talk about magic mushrooms, this is usually what they're talking about. These exert an agonist effect at the serotonin 5-HT2A and 5-HT1A receptors. Similar effects of other serotonin psychedelics at about 0.25 milligrams per kilogram of body weight when ingested. It's about 1/200th as potent as LSD and lasts about 6 to 10 hours. It's well absorbed orally. It's generally eaten raw, usually in pizza or something of that sort. And the hallucinations and sensory distortions resemble those produced by LSD. Recently, there has been some discussion of these drugs as being a potential antidepressant. Unfortunately, the research in that area was not placebo-controlled, so there is no way to know whether or not the participants got better because of using magic mushrooms or they just got better through some sort of placebo effect. So we'll have to wait and see for some better research in that area. So the final drugs I want to talk about are PCP, ketamine, and dextromethorphan. These are structurally unrelated to other psychedelic drugs because they are glutamatergic and MDMA receptor antagonists. So these look unlike anything we've talked about, but PCP and ketamine are structurally very similar. They were first developed as surgical anesthetics, both PCP and ketamine. PCP had few of the problematic side effects of typical anesthetics. People did not have depressed respiration, but unfortunately these can produce bizarre and serious psychotic reactions, including agitation, excitement, delirium, disorientation, hallucinations, and out-of-body experiences. It generally resembles a schizophrenic state, particularly PCP. The problem with PCP is, again, it was briefly used as an anesthetic in humans. It was abandoned because of the high incidence of psychiatric reactions. In terms of the pharmacokinetics of PCP, it's generally eaten, snorted, or injected. It's most often smoked. Oftentimes, again, it's included in marijuana cigarettes. It has a very long half-life of about 18 hours. It's responsible for an amnesic effect. It's usually sold as crystal or angel dust. Its mechanism of action is it binds to and blocks NMDA receptors on glutamate neurons. One of the problems with PCP is it causes a very, very solid blocking of pain response, and as a result, people who are on PCP respond in no way whatsoever to pain. So tasing them, they seem sort of almost like Supermen because nothing hurts them. So again, it can be taken orally, sniffed, smoked, injected, and through moist tissues of the eyes, rectum, and vagina. About 5 to 10 milligrams produces relaxation, warmth, tingling, numbness, a bit of a high, distortions of body image, floating for 4 to 6 hours, maybe even a mild depression. High doses produce this analgesia I was talking about, which is this inability to feel pain. They can get into a stupor and coma, can become psychotic, have sudden mood changes, become disoriented, confused, quite delusional, and exhibit a variety of other side effects. So these people on PCP can exhibit psychotic-like effects. Ketamine, which is also known as Special K, is a drug initially developed as an anesthetic or analgesic. Its current primary use is as a veterinary tranquilizer and anesthetic. Its main benefit was safety. Again, did not depress heart rate, breathing, or blood pressure. It's a representative of what we call dissociative anesthetics, in which the subject feels separated from their sensory experience. It's increasingly used as a club drug, primarily done through diversion from veterinary supplies. And again, it's starting to increase use as a club drug. We'll talk about its pharmacokinetics here in a moment and how it's generally used. Interestingly, this might represent a new class of antidepressants. There is emerging evidence that an active metabolite of ketamine produces antidepressant effects in a single dose. So it's a very exciting group of research. So look for that in the future, because there's certainly the potential for this to be a good antidepressant. This is still used in some special situations medically. So it is available for use by medical professionals, but primarily it's used by veterinarians. So ketamine is sold to veterinarians dissolved in liquids. Its primary source of illicit use is diverted or stolen veterinary supplies. The liquid is usually allowed to evaporate, and the resulting powder is then usually delivered intranasally, so it's usually snorted. So usually the liquid is either left out to dry or it's put into an oven, something like that. 25 to 50% is then absorbed and rapidly distributed. The mean plasma elimination half-life is about 2.3 hours, so it's a relatively short half-life, but it is absorbed and rapidly distributed. The effects of ketamine include some visual distortions. People can sort of get lost in themselves, and oftentimes their blood sugar can get off and get in what's called a K-hole, and oftentimes a little bit of sugar will bring them out of it for some reason. It's the reason why you often see club kids with lollipops, if you were wondering. That's the reason for that. Dextromethorphan is the last drug we'll talk about in this class. It's a common ingredient in more than 140 varieties of over-the-counter cough suppressants. It's increasingly used for getting high. It's very dangerous because you have to take a lot of it to get high. It causes increased blood pressure and heart rate and produces psychological behavioral activation and other somatic effects. So it's something really I would not recommend because it does have some pretty toxic side effects. So that's our introduction to psychedelic drugs. We're going to turn next and talk about marijuana will be our next topic up.